Dear Chairman, thank you for the invitation to present at the Euro Bifurcation Club 2021. The title of my presentation is Impact of Lesion Preparation Technique on Side Branch Compromise in Calcified Coronary Bifurcations. This is a subgroup analysis of the Prepare-Calc trial. The Prepare-Calc trial was a randomized trial in which 200 patients with severe calcified coronary lesions were randomized 1-to-1 to either strategy of scoring cutting balloon or rotational atherectomy, followed by implantation of the sirolimus eluting stent. As you can see, the primary endpoint of the trial was strategy success and was significantly higher in the group of patients treated with rotational atherectomy. In the main trial, we observed a trend towards more compromised side branch at the end of the procedure in the group of patients treated with scoring cutting balloon. But that was a per protocol analysis, and side branch compromise was not clearly defined in the protocol of the main trial. So we decided to focus on this group of patients. This was a post-hoc as-treated analysis of lesions located at bifurcation segment. So patients in those crossover from scoring cutting balloon to rotational atherectomy was done were included in the rotational atherectomy group. 2 interventional cardiologists, none included in the main trial, reviewed all coronary angiograms and index procedures to collect more details concerning the anatomy of the bifurcation, the steps of the PCI, and the angiographic region result at the bifurcation. And the primary endpoint of this analysis was compromised side branch and was defined as any significant stenosis of more than 70%, any dissection of the side branch, or final TME lower than 3. Here is the study flow chart. As you can see, from the 278 lesions included in the trial, 14 lesions were crossover from rotational atherectomy, from scoring cutting balloon to rotational atherectomy in the bifurcation group. And finally, the scoring cutting balloon group included 47 lesions in 43 patients, and the rotablation group were 68 lesions in 61 patients. Here you can see the baseline characteristics, which were comparable between the 2 groups with a more previous myocardial infarction in the scoring cutting balloon. The mean age was 75 years. And the angiographic characteristics were also balanced within the groups, and lesions were mainly located in the left anterior descending artery, and the true bifurcation was the case in 49% in scoring cutting balloon versus 43% in rotational atherectomy group. Concerning procedural characteristics, we observed more implanted stents per lesions in the scoring cutting balloon group. Other procedural characteristics were comparable. And concerning the bifurcation treatment, as you can see, casing or balloon dilatation in the side branch was performed in about 1/3 of the included lesions. We performed mainly 1 stent technique, and the most used 2 stent technique was keylot stenting. Concerning the primary endpoint of this analysis, compromised side branch at the end of the procedure were significantly higher in the scoring cutting balloon with 31.9 compared to rotational atherectomy group with 7.4%, and that was mainly due to higher rate of significant stenosis at the end of the procedure. In Peri-Procedural Complications, we observed a higher rate of large dissection in the scoring cutting balloon group compared to rotational atherectomy. And when we observe the biomarkers in patients with compromised side branch versus no compromised side branch, we observe a higher peri-procedural elevation of the cardiac biomarkers in patients with a compromised side branch. This study has some limitations. That was a post hoc analysis, included about 1/2 of the patients included in the main trial. The study was not powered for the detected difference, so the results should be considered hypothesis generating. And concerning the number of 3 bifurcation lesions, lesion preparation with scoring cutting balloon or rotational atherectomy in the side branch was performed in a very limited number of lesions. In the conclusion, we will say that in severely calcified coronary bifurcation lesions, we observe significantly higher rate of compromised side branch in the group of patients treated with a scoring cutting balloon compared to rotational atherectomy. Side branch compromise was associated with more extensive peri-procedural myocardial injury. So in calcified bifurcation lesions, an upfront rotational atherectomy with its debulking effect could optimize the result in the side branch. And thank you very much for your attention.